Okay,
That's fine.
So thank you very much to be invited in this Congress. I thank you, the President, and all the scientific committee. So my presentation is about craniosynostosis, and I will introduce it. So the important thing is to understand that the brain grew up as the school at about for a double in the first 24 months of life. So this is very important to understand the craniosynostosis. As you can see in this slide, the brain shape became more than the double in the first 24 months of year. So it could help us to understand the timing and the surgical technique for craniosynostosis. So a classification of craniosynostosis, we have primary and secondary craniosynostosis. Primary craniosynostosis, we have single suture and multi-suture. Single suture are even classified in non-syndromic craniosynostosis and plurisutural in non-syndromic and syndromic craniosynostosis. The monosutural non-syndromics are the most common craniosynostosis, like Scaphocephaly, Plesiocephaly, Trigonocephaly, and Pachycephaly. Multisutural non-syndromic are Brachycephaly and Oxycephaly. Multisutural syndromic are common like Cruzon disease, upper disease, Setter-Chosen disease, and Pfeiffer syndrome. Even secondary craniosynostosis that are not due to early synostosis of cranial suture are Arler and Morquio syndrome, rheumatism and hypothyroidism, thalassemia, and some drug toxicity like retinoic acid during pregnancy. It is important to understand that we need a multidisciplinary team to for the management of craniosynostosis, so maxillofacial surgeon, plastic surgeon, dentistry, pediatrics, ophthalmology, and radiology. Normally, we have this timing for the normal closure of sutures, so we can see it is about in the first 24 months of life that all cranial suture will be closed. So to let the brain grow up. It is important to understand that the cranial vault anomalies are strictly connected with school-based anomalies and orbitary anomalies. In this slide, you can see how it can change the cranial base shape due to cranial vault anomalies. Sometimes, and this is a slide in which we have a very complex craniosynostosis, we have even the school-based anomalies in that due to Chiari malformation in this case that I will explain later. So those are the most common single suture craniosynostosis in which we would have the trigonocephaly, the scaphocephaly, anterior plasiocephaly, brachycephaly, and posterior plasiocephaly. Normally, we could have some genetical abnormality in craniosynostosis. So you can see that most involved genes are FGFR, so fibroblastic growth factor receptor, 2,3 and 2,3C, and then FGFR3 and twist gene. There are, as you can see, quite involved in anterior plasiocephaly, in brachycephaly, and of course in all syndromic craniosynostosis. The indications and principle of treatment of craniosynostosis are three kinds. The first one, of course, is ICP consideration. So intracranial pressure, then ophthalmological, and then aesthetic. Of course, the principle of treatment change in the pediatric age and in adult age. In pediatric age are in the most case functional consideration. In adult age, it became much more aesthetic. The functional are, of course, visual loss, pain, intracranial hypertension, and airways and pharyngeal problems, especially in the syndromic craniosynostosis. Sometimes it could lead to speech problems due to deformity, proptosis, of course, and aesthetical consideration. So we start with the most common and simple craniosynostosis, that is a scaphocephaly, that is due to the early closure of the sagittal suture. And so the head will develop this kind of shape, so elongated shape, because normally the growth of the head is impossible perpendicular to the synostotic suture. So in this case, with the sagittal suture closure, we have what we call scaphocephaly. So it's like a elongated head with a prominent forehead and even occipital bone. In this, the diagnostic is just clinical, but in this slide, I show you some radiological aspect in which you can see this ridge of the synostotic suture. The surgical indication for scaphocephaly are mainly aesthetic. There are some controversy about intracranial pressure, and if there is a compensated scaphocephaly, so some is a partial suture fusion, like dolichocephaly, is not indicated any surgery. The principle of treatment, of course, are less than 6 months, from 4 months to 6 months of age is the most simple surgical treatment. After 6 months, it became much more complex. This is normal surgical positioning, so it's prone with the extension of the head. Those are the kind of incision we can perform. In the mid one, the S italic is one of the normally incision we use to perform it. It extends from the anterior fontanelle to the inium. Or sometimes you can even prefer bitragal incision or zigzag as a aesthetic problem. So this is the most simple surgical treatment of scaphocephaly. This is the stripping of the sagittal suture, in which you remove just the synostotic suture, giving in this way the opportunity to the brain to grow up, so push again laterally during its growing, and so to condition the shape of the head itself. Those are much more invasive surgical treatment, that is the cranial vault remodeling, that is now no more used. It was in the past. Or even the P. Greco technique that it's sometimes used, in which you just create an osteotomy corridor by the side of the suture and opening the anterior fontanelle. And in this way, you can achieve a good result, because you give to the brain the opportunity to grow up even laterally. And this is the imaging. Those are some examples of preoperative and postoperative in which you can see that we could have a good result, aesthetic result in scaphocephaly. Well, in the recent time, there are several new techniques, like, for example, this one, a minimally invasive approach using an endoscopic assisted craniectomy for scaphocephaly. This is our experience, in which we performed a couple of small incision anterior to the anterior fontanelle and the other one posterior on the inium, in which we performed this kind of osteotomy with less blood loss. And it's maybe the main problem for this kind of surgery. Those are some XR control. And those are the results. This one is the trigonocephaly. So it is the metopic suture that is involved. And This is the typical triangular shape of the forehead with even other kind of implication for the skull base. Usually, so this is the normal shape of the head in the trigonocephaly, in which we get the triangular forehead. There is an hypothalamusm and even supraorbital hypoplasia. Usually this one is the incidence, so it's 1 on 15,000 live birth, and it represents about the 14% of craniosynostosis. In this study, we describe how the skull base is changed in trigonocephaly, because there is the involvement of even the skull base suture. And this is our classification, in which we have 3 kinds of. The type 1 is the norm-only early metopic synostosis, just with the frontal ridge. The type 2 is early metopic synostosis plus frontal hypoplasia with the orbital ridge hypoplasia and even thickening of upslanting medial walls of the orbit. The type 3 included even ethmoidal hypoplasia and so hypothalamusm, because the involvement of the skull base. Those are the clinical aspects of the 3 different kinds, in which you can see how the type 3, the hypothalamusm is very important. This is the surgical technique. There is a bitragal incision, the exposure of the cranial vault, by frontal craniotomy, and then orbital ridge craniotomy, and then the remodeling. We usually turn 180 degrees the frontal bone. We create an artificial fontanelle, and then we make a construction of the orbital ridge that is, of course, remodeled, and the frontal as well. We use, in this case, of course, the resorbable plates that we put inside, and normally in 18 months, it's completely resorbed. And here you can see the intraoperative construction of the orbital ridge. And this is the preoperative image and postoperative image with a good result. Usually, as for the scientists of the bone, we use right now or biomaterial plates, like you can see here. There's polyglycolic acid plates, or even resorbable suture. Those are an example of preoperative and postoperative result. Here, another case. This one is maybe the worst monosutural craniosynostosis. Can you hear me?
Max?
Yes.
Come stai? Tutto bene?
Tutto bene, but can you hear me?
Grazie. Your time is out now.
Okay, so thank you
Caro
very much.
amico, io c'è un domanda, sì, in English.
Okay.
I wanted to ask you about the age for operation for this craniosynostosis. The ideal age for operation.
The ideal age is about 6 months, because we have, the child is big enough, and we have time, and he has time for the brain to grow up. So our surgical operation will help the brain to grow up. So he has time to grow up. And so for this reason, he could have time to resolve it.
After 1 year.
After 1 year?
Yes, some authors, they told they can operate for 4 years. Is this true? I don't know about, because I remember when we were in Italy together, the ideal age in the Center for Craniosynostosis in Meyer Hospital, yes, with the prostate surgery.
Yes.
It was from 6 months to 9 months. This is the ideal age for operation.
Well, we start, as you can see in these slides, early surgery at 4 months using less invasive technique. For example, for plagiocephaly, as you can see in this slide, we use a dissection resorbable device. And so we just make an osteotomy of the involved suture till the skull base, as you can see. And so we have a good result operating this child at 4 months of age. This is what we do right now.
Thank you very much.
Thank you very much. Thank you very much to you. Thank you.
Another question for Dr. Abdul Latif.
Thank you for this lecture. My question, if our baby with brain atrophy and craniosynostosis, what is your opinion about this case?
The brain atrophy is not a craniosynostosis. It's not a primary craniosynostosis. It's secondary to the brain atrophy. And so you can do nothing, because the principle of treatment of craniosynostosis is that the brain can grow up. And so it could determine the shape of the head. Normally, the head gets the shape because the brain is inside. If no brain, no shape.
Any other questions?
Yes, I have.
Okay, because of running of time, so we'll